Thank you very much for the invitation to come here and speak to you today, and particularly to Juan for inviting me. I'm based at the Institute of Hepatology, which is now located at the Royal Free Hospital. They had several different hepatology groups at UCL, and they've all been amalgamated now into one liver research centre, which is good. We now have a more powerful, I think, critical mass in order to bring on our developments. So I'd like to talk to you today, first of all, with a little bit of background for the scenario that we have in the UK at the moment, and then to talk to some of our observations, and then how those observations have led into the developments that we are trying to bring through. So liver disease in the UK is a very, very big problem. It's a very newsworthy problem. You can't go a week without a news item, a newspaper item, somewhere usually concentrated in alcohol, but there's a lot of media interest. And this came to light, it started to come to light about 4 or 5 years ago, where in parliamentary questions, statements were made by the health minister. One of them saying that liver disease is now the 5th most common cause of death in the UK, and it's the only cause in the top 10 that the rates are actually increasing. Out of those people tested in the UK, 1 in 25 shows abnormal liver function tests. There's a large number of people who haven't been tested at all. And between 1997 and 2001, alcoholic liver disease went up by 46% in the UK. By 2007, it then increased a further 2.5 times, 244%. The rate of increase is one of the things that attracts so much news attention. It's not just in the UK. In the US, there's more than 2 million Americans estimated to suffer from alcohol-related liver disease. Hepatitis B, and the Hepatitis B Foundation estimates us somewhere in the region of 350 million people worldwide, with around about 350,000 of those in the UK alone. With hepatitis C, there's around about 130 million people worldwide, 500,000 of those in the UK. And in 2000 in the UK, liver disease killed more men than Parkinson's disease and more women than cervical cancer. The rates, again, of liver disease are increasing, the rates of the other two are decreasing. We put this up because it's a little bit of a sore point in that both Parkinson's disease and cervical cancer, both independently, receive more money and funding than liver disease. And we can't get away from the fact that obesity is now the biggest problem in the UK. Obesity has overtaken alcohol as a major cause of liver dysfunction. Here we're following the trend set by America. We used to be around about 8 years behind America in terms of obesity and bad living styles. We're down to about 4 years at the moment, and that gap is narrowing. And what's probably a little bit worrying is that where America leads and Britain follows, the rest of Europe eventually catches up. You can see again just the trend that we see increasing. Our health service categorises things so that we can look at the statistics. Statistics from 5 years ago show that we had increased admissions and increased bed days for the very specific disease of the liver, not counting any other conditions and where liver disease was an associated factor. We're seeing a rise in new diagnosis of alcoholic cirrhosis of the liver. So we're now up to probably over here somewhere in the region of 30 to 35,000 new diagnosis, first-time diagnosis of alcohol cirrhosis. Not liver dysfunction, not a little bit of fibrosis, the actual cirrhosis at the end stage. And again, the trends here is that alcoholic cirrhosis was traditionally a white male 55 plus disease. What we see is that it's now being spread more evenly over the genders, and the age is coming down. If you look now, the most prevalent diagnosis rate is now in the 45 to 54 age groups, which dropped 10 years and is dropping further. We're seeing it in the 35 to 44 age groups. And you don't see it so much in this trend, but we're even starting to see it down in these 15 to 24 age groups. That's a very worrying problem for us. And one of the problems is that really our treatment options are still limited. If you take the idea or the concept that someone progresses with liver function, now whether they are stable with some evidence of cirrhosis or whether they were perfectly normal, and they encounter some type of insult. Now either this could be an acute insult causing an acute liver failure, or they could have a chronic disease and this be an insult that brings on an acute on chronic episode. If nothing is done to arrest it, that trend will carry on, the liver will fail entirely, and the patient will die. At some point, there's a threshold for organ failure, which is as independent as the patient. It's very hard to put an accurate level on what this is for an individual. And what we know is that depending on where we intervene and what the interventions are, we stand a reasonable chance of affecting a recovery. Obviously, it stands to reason that the earlier we go with an intervention, the more chance there is of a positive outcome. But still, the options here for these interventions are relatively limited, which is why we come around to the concept of having a liver support device, some type of artificial system that will support the liver while the body has a chance to recover. So, if we are creating a liver support device, we have a primary goal of a recovery of the patient to normal health, at least in the case of an acute liver insult. If they already have a chronic state, then at least you want to put them back to the level they were when they were stable, if not in some type of improvement. If these are too difficult to achieve, then the idea of at least having a bridge to liver transplantation. If someone only has hours, or a lifespan measured in hours because of the nature of the liver disease, if you could give them another 24, 48 hours, the chances of a donor organ becoming available are that much greater. If we can prevent the progression to liver failure, that would be good, although it's a little more difficult to define. But improvement in end organ function, or perhaps the prevention of secondary organ failure, is another goal that we're actively pursuing. Generally speaking, two types of liver support device. One of them is the biological system. Cell-based systems is very difficult technology. It's very hard to get a stable population of cells, get them working, and transport them to where they need to be. There are a number of ethical issues. Quite a lot of these cell-based systems either work on transformed tumor cell lines or they work on animal cell lines. Either one comes with a list of issues. And the cost of it is astronomical. And in order to make enough cells, keep them happy, transport them, and effect a treatment, the technology is very, very expensive indeed. Our method is to follow the artificial line. Simple, straightforward, well understood dialysis therapy, dialysis-based therapies. The technology has been established for years. It's also generally accepted. If you were to say to a patient, look, we will give you a liver dialysis, it's just like a kidney dialysis, but for your liver, they'll be happy with that. If you have to explain to them why we're going to hook them up to a large bioreactor full of cells, it's a little more difficult to explain. And relatively inexpensive. Nothing in medicine is cheap. But compared with the cell-based systems, the cost is maybe a tenth. Has this been tried before? Well, naturally it has. The idea that you could develop a liver-based dialysis system has been around for years. The one that's received an awful lot of press and a large number of studies is the molecular adsorbent recycling system, MARS. We've had a lot of personal experience with this. This uses an albumin-based dialysis system, where the albumin and the patient's blood never actually interact. The blood stays on one side of a membrane, the albumin solution stays on the other side of the membrane, and the idea is that toxins are pulled from the blood over to the albumin side and removed. The albumin then passes round a circuit, and in the process of passing through the circuit, it goes to a number of columns that clean the albumin and then present it as fresh against the blood. The Prometheus system is not that different. The difference, I'll show you a little figure in a moment, but the Prometheus system separates red cells from plasma, and the plasma is passed over columns to clean it, and then recombined with the cells and returned to the patient. A simpler version available in a large number of institutions is a single-pass albumin dialysis system, or the SPAD system. This is similar in principle to MARS, where you have a membrane with the blood on one side, an albumin solution on the other, but rather than the albumin solution being cleaned and recirculated, it passes straight to waste. So it's a single pass, one exposure to the albumin. Key thing about all of these systems is they don't actually do anything with the albumin in the patient's blood. They're designed to strip toxins, to strip metabolic byproducts from the blood, but they don't actually change anything fundamentally within the blood itself. There were a number of earlier systems. At King's, as you mentioned earlier, they started off with a charcoal perfusion system around about 30, 35 years ago, which was an unmitigated disaster. But people have tried a number of things. The idea of a liver dialysis system is really quite attractive. So here we have the single pass system. Very simply, patient's blood comes through a filter. The pore size on the filter is such that no blood product or blood and albumin stay on the patient's side. The albumin dialysis solution passes on the other side. Toxins are pulled across and sent to waste. And you have the option to rebuffer or adjust the volume of the patient's blood before it returns to them. Very simple, very straightforward. All the components are generally available on the shelf in the renal unit. The Prometheus system. Here you have the blood. It passes through a plasmapheresis filter. The plasma is separated. That passes over some absorbers and filters to clean the plasma, to strip the toxins directly from the albumin in there. It's recombined and then goes through a renal dialysis hemofiltration circuit before returning to the patient. Then we have the Mars system. The Mars system with the blood from the patient stays on this side of the membrane. The albumin solution stays on this side of the membrane. And the albumin is then taken, passed through a hemofiltration circuit, and then past activated charcoal and an anion exchange resin to pull off the toxins. There's a picture of the Mars circuit. I don't have a Prometheus one with me, unfortunately. So we have the hemofiltration system here, the Mars system there, and you can see here the charcoal column and the anion exchange resin column cleaning the albumin. So this is the basic premise of the SPAD or the Mars circuit. We have a dividing membrane here, albumin on one side with the toxins bound, and these toxins come off, pass through the pores in the membrane, and are attached to clean, free albumin on the other side. This then is recirculated, and as the albumin comes back again, all fresh and with the toxins removed, is presented to the blood again as clean. Unfortunately, both the Prometheus system and the Mars system failed in their pivotal clinical trials. When they were set up, and their primary goals were to reduce mortality and improve survival rates in a patient, admittedly a very sick population of acute on chronic liver failure patients, they failed. They failed to achieve any significant difference at all, and in some indications actually may have had a detrimental effect. But it's not to say that it's not good for some things. The Mars system is very good at some things, and Prometheus as well. We've demonstrated that it's very good at removing protein-bound drugs. Here, this was a patient study where we removed phenytoin, an anti-epileptic drug, from a patient. We've also shown that it's very good at removing anesthetic agents, such as midazolam, fentanyl, and albumin-bound antibiotics are also very effectively taken off. So if you have an overdose system, and there is a licensed indication for drug toxicities in the US, Mars is very good at taking it off. We've also run a program at the Royal Free for patients with intractable pruritus, usually PBC, PSC patients, who have an uncontrollable itch. They have a problem in that their only cure is a liver transplant, but they don't meet the criteria for transplant because their liver function is still sufficiently good, but the itch associated with the liver condition just won't go away. And we've had patients threatening suicide, patients taking wire brushes to themselves. I mean, it's a very sad story with a very poor quality of life. And we found that these patients do very well on Mars. Mars takes the itch away. And so pre-Mars treatment, post-Mars, we have a significant difference measured by the itch severity scale, which is our quality of life measure. Typically, our patients now come in at 3 monthly cycles for treatment, whereas they'll be showing itch severity scale, high itch severity scale, or VAS, which is the visual analog scale. There's a method of calculating their itch. That's reduced in one session, and within 3 months, their itch has sort of returned. They come back in. It's a single trip to the hospital. They stay in 3 days. They're not that sick. They actually stay in a hotel nearby and just come in for day therapy. 3 successive treatments. They go home again, and for 3 months, they're largely itch-free. It's a very satisfactory alternative to actually going through a liver transplant, and it's a very cost-effective alternative as well. This study in the States showed that Mars was very good at reducing hepatic encephalopathy, and in this study they showed that the effective wake-up was much better with Mars than with patients on standard hemofiltration. Well, a mechanism postulated for this, although it's largely still unknown, but the fact remains that even though there was no difference or no significant difference in outcome, patients still died. The reduction in hepatic encephalopathy was a very real and measurable event. A very quick look at biological systems. So these systems either utilize transformed cells or animal cells. There have been some with rejected donor organs, but if an organ is not good enough for a graft, the quality of its cells are really not good enough for a cell system either. The difference here is that they're not trying to just detoxify. All the artificial systems are really just trying to filter and take away something that manifests from the liver disease. In the biological systems, they're actually trying to take over metabolic and synthetic function as well. It is very expensive, and every single study that's been with a biological system has struggled to demonstrate efficacy. Not forgetting, of course, the ethical concerns of having either tumour cell lines or animal cell lines in the filter. So here's just a quick cartoon of two of the more sort of common, the Elide system and the Bowel system. Essentially, they still have cell masses maintained in the column of which plasma or an albumin solution is passed over. This is a picture of the Elide system that's been on trial recently. What you actually have is 4 columns here with cells in, and here the patient's blood is actually goes through a sort of plasmapheresis setup. A component of the plasma is out of the system and passed through over the cells, and then that cleaned plasma fraction is returned to the patient. Designed to be treated over a number of days. Very difficult to manage this, and the company actually supplied 2 technicians just to look after the machine directly while the treatments are going on. So that's what's out there at the moment. We're now talking about what we want to do. So our approach is to base our design on 2 of our fundamental observations. One, that albumin function is modified in liver disease. And I'll take you through how we come to this conclusion in a moment. And also that liver disease patients are more susceptible to infection. There is a problem with the immune response in liver disease patients. And in the UK, our statistics suggest that a patient with liver disease is 11 times more likely to develop sepsis in the ITU than a patient with a normal liver function. So we'll talk about albumin first. Albumin, abundant, multifunctional plasma protein, undertakes lots of functions. Ligand binding, transport, antioxidant. It's the main osmolyte in plasma, and can undertake enzymatic activities in the right situation. Albumin is exclusively synthesized in the liver. There are some very strange circumstances where albumin could be made elsewhere. Circulating concentration is known to drop in liver disease. There's a little picture of albumin. I'll show you a cartoon in a moment, but key regions are these binding sites. These are the fatty acid and drug binding sites. And this CYS34 is the main site of antioxidant activity on albumin. So here we have an increasing severity scale. On the bottom, control healthy subjects with around about 50 grams per litre or 5 grams per deciliter of albumin circulating in their plasma. Cirrhotic patients, stable cirrhotic outpatients that visit the clinics, are around about 10 grams a litre less. We have our acute hepatitic patients here showing a decrease below 30, regardless of whether they survive or go on to die. And our acute on chronic liver patients are around about the 20 grams per litre mark. This cartoon just looks at some of the functions that we attribute to albumin. One of them, we have a number of fatty acid binding sites. This thiol ligand here is the main antioxidant, the first line of antioxidant defense in the body. It's not because it's a particularly strong antioxidant, but there's such a large pool of albumin circulating in the body that this, in terms of overall antioxidant potential, far outweighs anything else we have. We have the N-terminal binding site here, which will bind things like cobalt, nickel, copper, nickel. Doesn't mind cobalt, that's quite important. And albumin will pick up all sorts of things. It'll pick up iron. It'll pick up other circulating metals. That's very important because it takes those out and prevents them becoming pro-oxidant species. When we look at albumin in the reduced form, that is with a thiol ligand as an SH form, we term that mercapped albumin. That's albumin as you want it to be in its antioxidant-ready form. And in a normal, healthy adult, you'd expect to see somewhere in the region of 0.75 to 0.8 as a fraction of your albumin in this healthy antioxidant functional role. As you start to get older, the amount of antioxidant albumin drops off and it starts becoming non-mercapped albumin. So you're around about half of your albumin is in a good antioxidant form. Patients with chronic liver failure, regardless of age, showing around only about a third of their albumin is ready to act as an antioxidant, and those patients we see in liver failure are down less than 10%. So already we're seeing a very simple functional effect on albumin that is depleting your antioxidant resources with an increasing severity of liver disease. We took this further and we wanted to actually look at the functional capability of albumin, and we used a relatively sophisticated method to do this. So we had a study where we have 83 healthy controls. Essentially, we just had a blood donor population that we took. We had patients who were stable but had cirrhosis and were coming back and forth to the clinic, 12 of those. And then we had patients with decompensated liver disease, 22 of these. These are in patients with an acute on chronic liver failure. And the method we used to look at these is an electron paramagnetic resonance-based spectroscopy method. So what we do is we take a reporter molecule, in this case a 16-doxyl stearic acid, which is a long-chain fatty acid mimic with a stable free radical on there. An EPR spectroscopy can detect and measure radicals. So we take this, and this will bind to the fatty acid binding site. So we have fatty acid site 1, 2, 3, 4. We're predominantly looking at 1 and 2, where we have the highest affinity for this label. Here we have the label itself. We get a very distinct EPR spectrum that we can measure. And when it binds to the albumin, each site it binds to is a slightly different environment. And the slightly different environment gives it a very slightly different line shape. And so we can have the pure line shapes here, the composite of our label stuck to albumin, and we can actually tease out this waveform from here. We can deconvolute the spectra and look and see how much is bound to site 1, how much is bound to site 2. We can then do several other things. What we do is we incubate these labels for a while. We look for transport functions. We introduce hydrophobic medium to the label as well to mimic the interaction that albumin has with hepatocytes when the structure opens up and it starts to release. And we can see how good the albumin is at picking up the labels, holding onto the labels, transporting the labels, and eventually giving up the labels. And to this we can attribute scores both for binding function, binding strength, transport function, and an overall detoxification ability. So the first thing we note is that looking at the binding constants, the strength of binding for the label is around about 100 for site 1, 60 for site 2 in healthy controls, and severely reduced both in the cirrhotic and the acute or acute on chronic liver failure patients. So we find the first thing we can see is that albumin is just not very good at picking things up. If it's not good at picking up this label, it's not good at picking up free fatty acids, it's not very good at picking up drugs. We look at the number of labels sticking into a particular site, so we expect to see 3 labels at binding site 1. What we find is that we have a decreased amount of labels attaching to the albumin. So it could be that there's something in there blocking the site, preventing things being picked up, or we could have a covalent change, actually changing the site structure, preventing the label getting in. Our composite measure, looking at transport efficiency, again, severely reduced, so around about 30% of normal function in a cirrhotic patient, and the acute patient around about only 15%. This is adjusted for albumin concentrations. We've already seen that these patients over here are around about 20 grams a litre albumin, less than half what you'd expect to find in a healthy individual. And of that albumin that they have, again, less than 20% of it is functioning as albumin should. Our overall detoxification efficiency shows the same thing. So around about 20% functionality, 25% for the cirrhotics, and less than 10% for our acutes. So we have a real problem here with the functional quality of the albumin. Even when you look at a blood sample from a patient and you see an albumin number and you think, well, okay, maybe that's fine, their albumin level is 25, it's 30, it's low, but it's not so bad. Chances are their functional albumin is a fraction of that. We want to know that if we put them onto one of these dialysis therapies, in this case the Mars therapy, does that change anything? Do we get a functional improvement in the albumin? So in this study we split our 22 acute on chronic patients into two. So we had 12 of them treated with MARS, 10 of them with standard of care. All of these received hemofiltration as a dialysis control. And we looked to see whether treatment, 3 MARS treatments over a 7-day period, so effectively a day on, day off, day on, day off regimen for the treatment, made any difference. That's the picture we've seen before. So first of all, there were some differences. MARS is very good at taking out bilirubin. Well, that's not terribly important, to be honest. It's very unfortunate if your patient looks yellow, but really the bilirubin doesn't cause any damage in itself. Creatinine is low because there's a hemofiltration component to both the MARS system and the patients receiving standard of care. No difference in prothrombin time. So there was no change in the ability of the liver to synthesize clotting agents. And you see that again with the INR. When we looked at the albumin function, we found no difference at all over the 7 days of therapy. So their strength of binding was unchanged. Actually got slightly better in the standard of care, but that's just a statistical anomaly. No difference in binding capacity, no difference in transport efficiency, and no difference at all in detoxification efficiency. So these patients, having gone through a week of therapy, having all the toxins removed from them, didn't fundamentally affect the quality of the albumin in their blood at all. And that's a real problem. For one thing, in order to make an efficient toxin removal device, you need to have functioning albumin to take the toxin from the body to the machine. So not only are you getting a problem where the albumin itself is not being changed, probably the efficiency of the actual treatment in pulling the toxins out is rather poor. Ultimately, there's no difference in outcome in these groups. The MELD got slightly better, but then we've taken out creatinine, and the albumin concentration levels didn't change at all. So that was fine. We also wanted perhaps a slightly easier method to look at albumin quality. So we became very interested in this Ischemia modified albumin score. This is a cobalt binding test that was licensed in the US as a rule-out study for heart ischemia. And the idea being that this uses a cobalt as a dye, and you put the cobalt in, and the cobalt that binds to albumin will remain colorless, whereas the cobalt that remains free in solution will develop a nice deep color. So essentially you're looking at a non-binding assay, where if the more color you get, the less effective your albumin is at being able to bind things. If it cannot bind things, it's termed to be ischemia modified albumin. And we thought, well, our patients obviously have got problems with their albumin. Let's see how this works. And initially, actually, it was no use at all. And then we sort of came to the conclusion, well, it's all very well and good to look at and see how much cobalt remains unbound. But that makes the assumption that everybody has the same albumin level. When we started to ratio that, so it became the ischemia modified albumin ratio, normalizing it to the concentration of the albumin, we started to come up with a very clear picture. So what we can see here is our control patients have a nice low score and the ischemia modified albumin ratio. And then with progressive severity of liver disease, we found more albumin is unable to bind the cobalt label. So this is a very quick, very inexpensive, easy method to look and see how effective your albumin is at binding ligands. And with severity of disease, obviously not very good. It shows some measure of outcome. So a difference between our liver patients, our survivors and non-survivors, was significant. One of the things that has been written a lot about this ischemia modified albumin test is that it all revolves around this N-terminal binding site. Well, we dug a little deeper and we looked into the literature some more, and actually cobalt is not that similar to copper or chromium or nickel, and it doesn't bind there at all. And what we can show is actually it binds at binding site 1 and binding site 2. The cobalt's happiest in that configuration. So this becomes actually a very quick, very inexpensive way to check and see what the fatty acid binding capability of your albumin is. And we got very strong correlations between our IMAR score and our very complicated EPR labeling score. This is prognostic. We get an area under the curve of around about 0.8. And if we separate our IMAR score by a value here of 0.02, we can see that we get a significant difference in survival. So we'll just sum up briefly there what we said about albumin. So it suggests that albumin damage measured as IMA, or by more complicated means, expressed a ratio to the protein, may be a useful tool to evaluate disease severity in cirrhotic patients. We found IMAR to be at least as sensitive as MELD in predicting outcome. And what we're saying is that this is probably due to some measure of oxidative stress that reduces the functional ability of albumin. We've also observed that there's an associated effect at the binding site 1 and binding site 2, which may reflect multiple points of albumin damage. So we're showing here quite categorically that, first of all, if you're a liver disease patient, you don't have much albumin, and the albumin you've got is probably not very good. So that's our first observation. Our second observation is to look at inflammation and infection. So in these studies, we particularly concentrated on neutrophils. Neutrophils being obviously one of the first lines of defense in the host immune system. And we've looked in patients with varying severity of liver disease. And we've noticed that with increasing severity of liver disease, there's an alteration in the base neutrophil function. And what we find is if I take neutrophils from a healthy individual, they'll be pretty happy, they'll sit in the tube, and they won't be activated, they won't be switched on, and they won't be producing free radicals. If I take the neutrophils from a liver patient, there's a pre-activation. Even though they're activated, and they're generating radicals in order to kill bacteria, if we put bacteria in with them, they're less effective at being able to consume it. So they have a functional inability to actually phagocytose bacteria. And we see here just the burst test, so on isolation, less than 10% of a healthy individual cells should be already activated. And with cirrhosis, or with an acute hepatitis on top, we find that 70–80% of an individual's neutrophils are pre-activated. They're all producing oxidative burst. They're causing damage by releasing this oxidative attack randomly without having a focus to work on. We can see this when we look at their ability to consume bacteria. So we label some bacteria, we feed these to the neutrophils, and then we look to see how many bacteria are taken up by the neutrophils. And we see that 100% in our control population steadily decreases with increased severity of liver disease. This again is prognostic for outcome, both in terms of the oxidative burst and also the phagocytic ability, both of which will show a very good predictive value. So something is switching on the neutrophils. There is an activating factor here. And if we take the neutrophils from a healthy individual and we put that with the plasma from a sick liver patient, we can induce this oxidative burst. So there's some transmissible factor in the patient's blood that when we add them to healthy neutrophils, suddenly switches them on, and we get this same spontaneous burst and inability to consume bacteria. And we see this here. We take normal healthy neutrophils, we take normal neutrophils and the plasma from a control patient, which doesn't have a high burst, we have no effect. If we take normal neutrophils and put that with the plasma from a patient who has a high burst already, that burst effect is carried over and the new healthy neutrophils are stimulated. What's also interesting is that's reversible. So if we take the neutrophils from a sick patient and we put that with the plasma of a healthy individual, we can reverse the effect. And we can see here these are the activated neutrophils from patients with liver disease. We incubate them with normal healthy plasma, and in almost all the subjects bar this one, we see a reduction in the amount of spontaneous burst. What is this activating factor? That's one of the questions we have, and we tend to believe that it could be endotoxin. So to test this, we've taken cells, we incubated them with increasing levels of endotoxin to see what the response is. We found that this giving endotoxin to neutrophils switches on the burst. And we see here, increasing levels of endotoxin, increasing amounts of spontaneous burst. If I take the plasma now from a patient and I clean it of endotoxin by passing it down through a detoxigel column and then incubating neutrophils with it, or if I give the neutrophils a specific antibody to block endotoxin on the cell surface, we can see that even though it's the same plasma, so the same plasma from a patient incubated with normal neutrophils, shows 75% burst here, an antibody to block the endotoxin being recognized, or cleaning the plasma endotoxin first, prevents its activation. So there's very strong evidence to show that endotoxin is a very strong activator of neutrophils. We show that if we put albumin in, now one of the things that albumin does is albumin will bind endotoxin and effectively take it out of the circulation. We already know these patients have got very low albumin levels. So if we start to supplement the albumin, we can show a dose-dependent response. So the more albumin we add in there, the more endotoxin will soak up, and the more effective we are at preventing this neutrophil burst. We can do this again with our endotoxin experiment, but this time just putting albumin into the tube And again, we see a dose-dependent response, where the albumin will sequester the endotoxin and prevent it activating the cells. So conclusions from this phase are the host immune system is indiscriminately activated in subjects with liver disease. And they're not focusing on a bacteria, they're just letting out these killing radicals, causing a lot of bystander damage. The activation is reversible, and endotoxin can act as a transmissible activating factor. So here now we come to the concept of our device. So the device we're terming the UCL-ARSeNEL device. So it's an albumin replacement system encompassing a novel endotoxin ligation. So the system, one, replaces the patient's damaged albumin. We know that if you give albumin, we can affect a positive response. But you can't actually quite automatically arrive at the assumption that damaged albumin is benign. Damaged albumin can have its own side reactions. It's quite possible that the damage that albumin accrues in liver disease gives it independent enzymatic function. The other thing it does is absorb bacterial endotoxins. So here we have our patient. The blood comes from the patient, passes through a plasmapheresis column. The plasma then, first of all, passes through an endotoxin trap. We then pass it through an albumin removal column. So we have 100 kilodalton pore size on here to allow albumin out. Albumin runs at about 67 kilodaltons. And then the cleaned plasma is returned, mixed back with the cells, and here we have a new albumin infusion. So we're taking albumin away, we're throwing it away, we're taking endotoxin out of the system, and we're putting healthy albumin back in. So go back to our cartoon earlier on. Previously, these toxins were moving across the membrane. Now we're working on a system where instead the albumin goes. The damaged albumin goes and it takes whatever's bound with it. The fresh purified albumin comes back in, and we're improving the albumin pool of the subject. We've taken this, we've tested in a large animal model. So this we did it in Germany, and we had 8 acute liver failure induced by acetaminophen or paracetamol, and 5 that we had acute liver failure and were treated by the device. Endpoints we looked at in this study are survival, intracranial pressure, which is actually the main cause of death in this model. We looked at standard biochemistry, cytokines, albumin damage, and plasma endotoxin levels. So here's our model. This is the prototype device, first generation. We have got a little bit smarter now, but you always have to start somewhere. Here's our patient. And you can see we've got full, effectively, ITU monitoring around here. We have the ventilation system here. We have all the supplementary drugs, fluids going in. The model is very aggressively maintained with fluid support. We also have measures here for intracranial pressure. We have flow probes on. We're measuring various blood flow distribution around the body. First of all, we should say that out of all the pigs we've done, no hematological or biocompatibility issues, no bleeds, no clotting effects that would be detrimental. The model is established based on the quick. So the quick time, or effectively a 3 times normal clotting time, is taken to be the point of irreversible acute liver failure. So we had time 0 is set when our quick hits less than 30%, or our prothrombin time goes 3 times normal. After that, treatment starts. They're either treated with the ARSeNEL device, or they get hemofiltration from this point onwards. And we also support the model. One, it's very difficult to get pig albumin. So in this model, we were giving FFP. So they get 2 units of FFP at the point of ALF in order to stabilize the model. And then the ARSeNEL animals get FFP added back into the system in place of fresh albumin. But we gave an equal quantity of FFP to the control group as well. And we saw, very pleasingly, a significant improvement in survival, or time of survival. So our ALF animals were running to about 16 hours, and we showed a 50% improvement to around about 24 hours on the device. So these are animals in full acute liver failure induced by paracetamol, no other treatments, no N-acetylcysteine, no drugs, the rest of it. It's just the device against control. Naturally, as the liver failure takes hold, we see a decrease in the albumin level. Even at the point of ALF, when we start giving some FFP in there, we see a slight non-significant increase in the device-treated animals, but no difference in the controls. And the albumin levels sort of go along quite close to 0 for the remainder. Ammonia levels go up. And in quite a lot of these measures, you'll see that apparently the device measures go up significantly higher or substantially higher than those in the ALF control. This is simply the fact they live longer. What we actually did is just delay the point of death. And as we delayed the point of death, there was lots of other metabolic processes going on, still producing a lot of the metabolites we're looking for. Mean arterial pressure. As I said, we have very aggressively controlled this with lots of fluids and with inotropes to maintain at least 50 millimeters of mercury mean arterial pressure. What we found is we had a significant reduction in the amount of noradrenaline required in order to maintain that pressure. So we have an improvement in the cardiovascular system. ICP went up faster in the ALF animals compared to those treated with a device. Eventually, the ICP levels in the device-treated animals went up the same amount, but there was around about a 6 to 8 hour delay in the increase rate. Likewise, we see with lactate that the lactate level went up faster and earlier in the ALF animals and was a delayed onset. So that suggests also you're having some positive beneficial effect on cellular safe and significantly increased survival time in a porcine model of acute liver failure. This device addresses these key pathophysiological observations that we've made, such as albumin dysfunction and endotoxaemia. These then have a significant effect on end organ function. So we're optimistic that we have an improvement in cardiovascular system, we have an improvement in end organ function in treating with the device. And we believe these findings justify clinical trial, and we're just in the process now of trying to negotiate that with the authorities in the UK. And I'm just going to summarize very briefly at the end. Is this the future for albumin dialysis? Well, this is one future, but the problem we have is that this still requires patients effectively to be in an ITU setting, or at least to be an in-hospital setting. So are there longer-term dialysis solutions that we could do in the community? And the obvious solution there is peritoneal albumin dialysis. And is this a workable solution to think about in patients with cirrhosis? I'm just going to put this out there as an idea for you to consider. If we go back through history, we can see that in 1877, the peritoneum is described as the largest of the serous membranes, with a surface area equal to that of the skin. So there's plenty of area there to work with as effectively a dialysis membrane. Lined with mesothelial cells, which project microvilli, projecting from the peritoneal surface. And these can be involved in the transport of soluble substances across the cell membrane. There's also a range of stomata, which overlie the lymphatic ducts, or lymphatic lacunae. These then provide a direct route between the lymphatic system and the peritoneal cavity. So a lot of uptake that happens from the peritoneal cavity goes through these stomata directly into the lymphatic system. And we see them here, these little black dots here, these are the stomata, and this diagram here, you can see stomata overlying the lymphatic ducts with a direct line then into lymphatic vessels. So if we do put something into the peritoneum, the chances of it being absorbed and taken up into the body are very strong. Some people have done some studies before. Peritoneal dialysis with an albumin solution, in this case a 7.5% albumin solution, results in around about a quarter of that albumin being taken up over a 4-hour period. The use of labeled albumin, in this case radioactively labeled albumin, show that it is the lymphatic system that this albumin is taken up into and then absorbed into the body. The investigations show that of the albumin absorbed, around about 50% will appear in the blood. A lot of the rest of it is taken up actually by cells and distributed around the body. Peritoneal dialysis has also been well tolerated in cirrhotic patients. So there's a study by Davies et al. Who showed that cirrhotic patients with end-stage liver disease tolerated peritoneal dialysis with an albumin solution for more than 12 months with no more complications in the control group. So the system does work, and it is very viable. And what you think of here is that even though the amount of albumin uptake and exchange, because we know that in cirrhotic patients albumin will leak into the peritoneal cavity and can then be removed. By putting albumin in and taken out, even if it's only a small fraction every day, you could effectively engineer albumin exchange over a long period. So the patients in the home, the cirrhotic patients who are starting to show evidence of albumin dysfunction, could be on a long-term basis effectively exchanging their albumin at home and hopefully reducing their list of complications. So this is now the subject, or at least part, of a European grant, of which this university, UCL, and other partners have participated. And hopefully, with the right amount of funding, we'll take this further and develop a working prototype of this system. And this is the system and discussion. I thank Juan again for stealing one of his slides today. very simply, you have a pump here, wearable fluid bags, one to drain, one to infuse with. You drain out the liquid in the peritoneal cavity, refill it with an albumin solution, allow it to dwell, and then repeat the process. The dwell time, the fill time, the amount of volumes are all yet to be determined. And that just leaves me to thank our funders in the UK, the Department of Health, the Wellcome Trust, Medical Research Council, our UCL business arm, and the Plasma Products Therapeutic Association for supplying us with money in order to do this work. Co-workers at the Royal Free, particularly Rajiv Jalan and Raj Mukherjee, who run the liver failure group that I work in. And we have our students here, and Vanessa, who's now left us and become a consultant in Graz in Austria. Gambro, who provided a lot of the dialysis technology that we're working with. And in Germany, Christian, Caroline Thiel, and Martin Schenk, whose model we used for the study. And I'd like to thank you very much for coming today and your kind attention. Thank you very much.